everybody. I'm just going to share my screen so we can dive right in. My name is Dr. Ilana Gurevich, and I am a naturopathic physician, and I am a fellow of the American Board of Naturopathic Gastroenterology. So I am hyper specialized in GI conditions. Today, the thing that I'm going to discuss is how to work up a GI case properly. A naturopathic segment by segment approach that I have learned and that I teach my residents and that I want to teach everybody because I think it's super important. I will say I talk very quickly, and of course I overstuffed this presentation, so I'm going to fly right by, and I'm sure you guys can re-listen to me on half speed if you need, but at least you'll get all the content that I'm trying to teach. Couple of financial disclosures. I run a residency program. It is partially sponsored by Diagnostic Solution Lab and partially sponsored by Enzyme Science. I am also a paid physician educator for Nestle Health Sciences. I am on the advisory board for All Clear Healthcare Laboratories and on the scientific board for Mosaic Labs. I also run a couple of podcasts because I have no other interests outside of functional gastroenterology and naturopathic medicine. So I run a podcast called The Turd Nerds, which is integrated gastroenterology based, and The Point of Medicine, which is autonomic nervous system based, which are actually pretty related. And then I am also the lead educator for SIBO Education, which is a hands-on injection-based platform. So the goal of today is really to be able to understand what workup to do, when to do it, how to do it, when you're not supposed to do a workup, and then understanding how to put together the chronic GI case. So what happens? Patients generally have been over-tested and under-improved. We see this clinically all of the time. Patients will arrive into our office having a stack of testing this big, extensive lab testing done, extensive amount of financial investment for that lab testing, lots of data, but no actual improvements. This happens because we are testing without a clear hypothesis of what we should be testing and when we should test. We don't have a strategy. Most failures happen not because of treatment, but because the workup was done incorrectly. Who walks in our doors? Very often, patients who are walking in our doors were given some kind of trash bucket diagnosis from the conventional world. IBS, functional GI, strep. They have had symptoms most likely for years, not months, and they have most definitely seen multiple providers before they're walking into our office. They've probably seen conventional providers, subspecialized conventional providers. They have tried diets, supplements, cleanses. They have done it all. They are most likely burnt out. They might be a little bit hopeless, and they are still symptomatic. Chronic GI clinical features involve chronic GI symptoms like bloating, distension, reflux, diarrhea, constipation, food intolerances that are generally getting worse every year, systemic symptoms like fatigue, hormone dysregulation, brain fog, and then their symptoms will often fluctuate. So they'll go back and forth between diarrhea, constipation, they'll have good periods, and then they'll go into a flare and they don't quite know why. Most likely they've had some kind of conventional workup already done. This might be colonoscopy and endoscopy. It might be an ova and parasite, which is, very specific, but not at all sensitive. They probably have tried empiric treatments like diets, like probiotics, like acid suppression, antibiotics. They might have done some kind of stool testing already. And they've probably done some kind of intervention, and oftentimes it hasn't worked. And the thing that really frustrates them is the fluctuation of their symptoms makes everything very unpredictable. Patients are still symptomatic. They're still symptomatic because the workup, A, might not have been correct. It might not have focused on where their actual problem is, or they've had the wrong workup done, or clinicians are not understanding all of the complexity that comes into these patients and how it might not be something that's easy to work up like a microbiome. It might be motility or nervous system in underlying cause. Why failures occur? The thing that I want to talk about is cost does not equal clarity. Just because you're running expensive tests doesn't mean you're running the right tests. And so now you've had patients spend hundreds, if not thousands of dollars, but you're working at the wrong organ or the wrong part of the GI. Some people will walk into my office and they work with providers that they ran a stack of every single test you can think of. They ran H. pylori, they ran small bowel, they ran large bowel, but it's like there's too much information and nobody can really understand what's happening. Also, patients burn out. They've tried all of these things and they immediately walk into my office and say, nope, I've done it. It doesn't work. It doesn't work. Tests have to be chosen, workup has to be done based on where there's a localization of the problem. Stool tests should not be used for small bowel problems. And if they're having a small bowel presentation, you want to start with small bowel testing. GI treatments and GI testing needs to be done with a clear understanding of what the underlying cause is. When I look at a GI, and I've been running residents for, I think, over a decade at this point, the first thing I teach my residents is different organs in the GI function differently. I chunk it out into the upper GI, middle GI, and lower GI. Upper GI would be the esophagus and the stomach. Middle GI is the small bowel. Lower GI is the large bowel. Each different segment has a different physiology, has a different microbiome, and requires a different testing requirements. So this presentation is going to be chunked out into these three different sections of the GI, and I'm going to try to help you flush out how to choose what testing to do. So let's start with the stomach and the esophagus. The key sign for upper GI pathology is symptoms will immediately worsen after eating. No relief with belching or vomiting. Oh, sorry. No, there is relief with belching or vomiting. Symptoms resolve in about 60 minutes after eating, maybe as many as 90, but it's not going to go much longer than that. And they're generally localized above the umbilicus. We are talking stomach and esophagus. One of the key symptoms might be early satiety. They feel full after just a few bites. They might deal with nausea, which may or may not come with vomiting. Epigastric pain that feels like burning or pressure or fullness or bloating. Symptoms will basically be a certain quality, not just location. And you basically need to match the treatment to the mechanism that causes the issue. I really want to dive into reflux for a couple of slides, mainly because it is so abundant and conventional treatment really fails here. So there's a lot of different potential underlying causes that can cause reflux. One is acidic reflux, where you have a dysfunction of the lower esophageal sphincter, and that leads to true acid exposure of the esophagus. You could also have a functional dyspepsia, which is impaired gastric accommodation, or also potentially visceral hypersensitivity. There might be a delayed gastric emptying component where you have food retention that leads to an uptake of pressure and nausea. And then there might just be a visceral hypersensitivity where everything functionally is normal, but symptoms becoming exaggerated. Symptom-based treatments will fail because you're not treating the right thing. And really, a lot of these underlying causes, the only information you have is the symptom, but they might be caused by different things. Underlying physiology may be completely opposite to what you think is happening, so you're treating the wrong thing. This happens a lot with acid-suppressing medications. And then, I'd be remiss as a naturopath not to talk about hyperacidity versus hypochlorhydria. Hyperacidity is the excess acid or impaired mucosal protection from that acid. That is resolved with a PPI, and that is often used in our conventional settings with PPI. Hypochlorhydria is insufficient acid production and impaired protein digestion and altered gastric signaling. Again, the presentation is exactly the same, but the underlying cause and the successful treatment is opposite. The treatment would be more acid, not less. I want to point out the value of very, very cheap blood tests, conventional blood tests that you can run through your national labs. The stomach sets the stage for all nutrient absorption and all macronutrient absorption. Inadequate gastric acid and mucosal integrity are, if you have inadequate gastric acid, you have inadequate absorption. You need the right amount of gastric acid to liberate nutrients from food and to signal downriver digestive effects like the pancreas and the bile to start preparing to start mobilizing out those macronutrients. When you don't have proper gastric function, you have an impaired absorption downriver. Nutrients will often be the first thing that appears wrong. So low iron, B12, zinc, magnesium are all dependent on gastric processing. And so if you're seeing this broad micronutrient deficiency, this should be percolating in your brain. Deficiencies develop before structural disease and abnormal imaging. This is going to be your first sign. And low normal can give you some insight. We're not only looking at frank disease states, we're looking at getting people out of these optimal ranges where they're starting to be symptomatic, but we're not seeing anything organically yet. Normal scopes and CBCs also do not rule out gastric dysfunction. Nutrients will reflect functional performance, not just disease, and deficiencies can localize a problem way before any other testing organically finds it. Iron and ferritin are especially important when we're talking about stomach acid. So gastric acid is essential for pre-processing or converting ferric iron to ferrous iron, which is much more absorbable in the duodenum. And so if you have reduced acid, you have a decrease in this iron solubility, and so the duodenum can't pick it up. Also, that's true for ferritin. Low ferritin often signals some kind of impaired gastric function. When you have adequate stomach acid and good mucosal integrity, then iron absorption happens very easily. But if you have chronic gastric hypochlorhydria or some kind of occult bleeding, you see low ferritin coming up. Also, medications that can lower ferritin, acid suppression, antibiotics, NSAIDs, anticoagulants, and many other pharmaceuticals. B12 is another one that really relies a lot on gastric function, appropriate gastric function. B12 has to be released from food via intrinsic factor. So reduced acid secretion prevents proper release of B12 from the dietary sources, and then that reduces the absorption because the intrinsic factor can't pull it in. Zinc also relies on proper stomach acid and healthy proximal small bowel mucosa. If those are not functional, you will start seeing low zinc. And zinc is a little bit of a self-perpetuating cycle. Poor zinc absorption worsens zinc deficiency, which then worsens gastric and intestinal mucosal integrity and barrier function. So this is just a loop that goes round and round. There's lots of different gastric physiological things or physiological factors that can make a issue. The stomach is an active regulator of digestion. It's not just a passive reservoir. The stomach is responsible for acid secretion, which leads to protein denaturization and mineral and vitamin release. Mechanical digestion, which breaks down foods into smaller particles, neurohormonal signaling, which triggers pancreatic enzymes and bile flow downstream, and then the preparation of nutrient liberation so we can properly absorb in the small bowel. We need to always talk about H. pylori. H. pylori is over-tested, over-treated, and also important. However, there are times when H. pylori should be treated. I want to first direct you to an amazing book that was written about H. pylori called Missing Microbes. That is very, very useful if you're looking for a bigger H. pylori picture. Indications are unexplained iron deficiency or low ferritin, low B12 without a clear dietary cause, refractory dyspepsia or epigastric pain, persistent symptoms despite acid suppression, prior negative testing, even though symptom clinical pictures match. When testing, when should you not test, or when should you not point out that there is issues with the GI? If there's no upper GI symptoms, I am not going to go after H. pylori. If they're not having acute pain, pressure, epigastric pressure, ulcer-like presentation, even if it shows up on testing, I am going to leave it alone. I need a clinical picture to match that finding. Repeating tests without reassessing gastric physiology that shows abnormal findings might lead me in that direction, but most important, I need a clinical picture to match. H. pylori is very prevalent in the GI tract all over the world. H. pylori colonizes more than half of the world's population, yet most people who have H. pylori are asymptomatic. The presence alone should not point you in the direction for treatment. Absolutely. The presence alone tells you that they have a diverse microbiome in their stomach. It is part of the gastric microbiome. Humans will harbor complex microbial communities. H. pylori is one of those microbes in the community, and it is not necessarily harmful. It H. pylori influences the microbiota. It influences your immune system. It modulates the gastric and broader gut microbiota and interacts, abundantly with the immune system. It helps shape immune response or microbiome balance rather than directly driving disease. And what we've noticed is, one of the theories that we have based on that missing microbe book is that if we remove H. pylori, we do have other issues that lead to further dysbiosis downstream. There is a pretty high growing evidence that talks about H. pylori as the big controllers of the leptin ghrelin pathways, and eliminating H. pylori from the microbiome can be one of the reasons why we have so much more obesity. That is one of the theories that's happening right now. There are times when I'm a lot more guided to treat. H. pylori, there's a lot of different strains that we know about. Some of the virulence factors are much more valuable to treat than others. CAGA and VACA have been found to be more correlated with ulcers and also with gastric cancers. So if I have a symptomatic patient with these virulence factors, I am going to be more inclined to treat, and I am going to be inclined to treat pharmaceutically. OIPA and BABA are other virulence factors that change the way that H. pylori interacts and can make it more viral or can make it cause more diseases. When is an endoscopy indicated? Because really, if we're just treating functionally and not treating, if we're just treating functionally and forgetting about organic underlying causes, we're going to get in trouble and we're going to really make the patient feel worse off. So red flags: unintentional weight loss, GI bleeding or frank iron deficiencies, progressive dysphagia, persistent vomiting, nocturnal symptoms. When we sleep, we should not be eliminating. Continued GI symptoms, despite appropriate and time-limited therapy. You think there's probably something going on, you're treating the wrong thing. Nutrient deficiencies that are unexplained, and structural diseases like ulcers, like severe gastritis, like malignancy. If you have any of those as theories, you need to send them for a workup. When the stomach isn't working, then we move on to the small intestine. Sorry, if the stomach has been ruled out, then we move on to the small intestine. So this is what I call the middle GI. The middle GI causes a lot of issues. And the problem with the middle GI is that access is very limited. It is difficult to visualize the small bowel. With endoscopy, you see the very, very beginning of it. With colonoscopy, you see the very, very end of it, but the middle is often missed. Testing is often misapplied. Stool tests should not be used to see what the small bowel physiology or pathology is happening. Empiric treatments without confirmation are also not useful. So I once heard an analogy that basically said the microbiome of your large intestine has more in common with the microbiome of the intestine of a mouse in their large bowel than it does with your own small bowel. So if you are collecting a stool sample, trying to assess what's happening in the small bowel, you are not seeing any of that. That stool sample that you are collecting is showing you what is happening in the large intestine, not the small intestine. Small bowel pathology is generally non-specific. Bloating, pain, food reactions, IBS without any localization. It really is a difficult organ to assess because it's hard to get there and it's a very long organ. Also, motility and fermentation disorders do not show up on imaging. So really, you have to do some very expensive testing to understand what's happening with motility. The small bowel has a lot of roles in digestion. One of the things that it utilizes is the migrating motor complex, or the MMC, which is a cleaning wave that runs between meals. If your patients are perpetually snacking, this cleaning wave is not working. Clearance of residual food and microbes are reliant on a functional MMC. And then if you have food stagnation or the MMC isn't working, you end up with overgrowth of bacteria and food stagnation. Digestion and absorption happens in the small intestine, breakdown and uptake of your macronutrients, carbs, proteins, and fats, absorptions of most of your vitamins, iron, B12, folate, magnesium, and the fat solubles. High surface area is there for maximal absorbability. Bile and enzyme interactions occur. You have a mixing of gastric chyme with pancreatic enzymes. Bile-mediated fat emulsification should be occurring, and antimicrobial effects for bile acids. There are Peyer's patches and gut-associated lymphoid tissue because there's a huge immune component that happens in the small intestine. The immune system will sample different food antigens and microbes, and with that process, if everything is working great, then it can regulate immune tolerance and activation. Why small bowel dysbiosis persists? Well, you have a failure in any of those mechanisms. The migrating motor complex becomes disrupted or impaired. This happens with some kind of anatomical changes. This could also happen with stress responses, hormone responses, medication responses, interference with infections or clearance, and then also lifestyle choices that shut down the migrating motor complex. There is potentially structural and mechanical factors that can interrupt this. Adhesions, prior abdominal surgeries, endometriosis, adenomyosis, any abnormality into the abdomen can cause structural changes. And then you can have kinking or pooling of the intestine. And then you can also have upstream dysfunction, impaired gastric acid and signaling, inadequate enzymes, inadequate bile delivery. The small bowel relies on a feedback loop. So if you have overgrowth, that will further slow motility. Gas production will increase pressure and discomfort, and then recurrent refractory SIBO patterns can emerge where, because of the lack of physiology, you end up with more of these bacterial changes. Absolutely, neurological and hormonal influences play a role. An imbalanced autonomic nervous system is key and unfortunately very easy to put out of balance. Serotonin signaling and disruption, and then you can have change with your hormonal pathways with estrogen and progesterone affecting transit. Without addressing the underlying driver, you really can get in trouble. Small bowel role in digestion. So small bowel is the controller of the microbiome. It regulates digestive delivery. That is enzymes, that is bile, that is pancreatic signaling, that is immune response utilizing Peyer's patches, antigen sampling to develop oral tolerance, and that is bile flow for emulsification, antimicrobial effect, and hormonal clearance. So the small bowel is the controller of the nutrient status with a lot of immune system present. A small bowel symptom cluster involves postprandial bloating. So one of the big things that patients will walk in and complain about is, I wake up flat, and by the end of the day, I am distended. I am looking 3, 6, 9 months pregnant, and I don't start that way. Bloating worsens as the day continues. They will often complain with a gas that may or may not cause stool changes. Periumbilical discomfort is really what you're looking for. Pain is located around the belly button and around the middle abdomen. And then oftentimes these patients will have issues with fermentable food issues. Symptoms worsen with fermentable foods like carbs, sugars, and fibers. They will often present with escalating food intolerances. Food that they used to previously tolerate are now triggers. They have a broadening list of problem foods, often mislabeled as histamine intolerance or food allergies. IBS-D, IBS-C, IBS mixed. Bowel changes are common in small bowel patterns, even though they're not required. The small bowel changes, the stool changes are secondary to some kind of small bowel dysfunction. And this is where it gets a little bit nuanced when you have to take a really good history with a patient to figure out if we're dealing with a small bowel or a large bowel issue, because both of them can have stool changes. Methane for bacterial overgrowth in the small bowel is more associated with reduced transit and constipation, while hydrogen is more associated with bacteria. They will poorly tolerate fiber and prebiotics, where oftentimes their bloating will get worse the more good, healthy gut foods they eat. And they oftentimes don't have complete relief from antidiarrheal agents or laxatives. That doesn't take care of the problem. When constipation and diarrhea coexist with bloating, bloating is present in 70% of small bowel pathology. So that's really one of the key triggers you're looking for. And you're also looking for, when does it get worse? Do you wake up good and get worse during the day as soon as you start eating? That should make you think small bowel. The post-infectious SIBO picture is super important. What happens is there's some kind of acute gastroenteritis that can damage small bowel motility. Inflammation and immune activation will impair the migrating motor complex, and then reduce clearance allows the bacteria and archaeal growth or methanogen growth to take over, and then symptoms will persist the longer the infection happens. And they could be dealing with an infection that happened 20, 25, 30 years ago that is still persisting. You have onset that often occurs after a stomach flu or a GI bug. Bloating, gas, and then change of bowel habits are common, and they're often labeled IBS without a clear understanding of why. Post-infectious IBS is frequently a motility-driven small bowel disorder that affects the microbes. And so you have to have that in your mind. Treating microbes alone without restoring motility is going to lead to recurrence. And so one of the things that we do really well is prioritizing A, antimicrobial treatment, B, prokinetic supports, and C, GI restoration. There's lots of conditions that can predispose to bacterial overgrowth. Post-surgical changes. We talked about adhesions and how adhesions can affect small bowel physiology. Any abdominal surgeries, a gastric bypass for obesity, gastrectomy for peptic ulcer disease, gastric cancers, intestinal adhesions will cause kinking and narrowing. Those organs should be, we always describe them as being like, butter between parchment paper. But if you have adhesions, now all of a sudden that organ can't move. And that basically turns a flowing river into a swamp. Like if you can't move, you can't clear the bacterial overgrowth. You can't use the body's natural physiologic approaches to deal with it. Small bowel diverticulosis is also another thing that can cause stasis. And then inflammatory disorders, Crohn's, radiation enteritis, scleroderma, celiac, diabetes, all of those conditions can affect transit and affect motility, which will then predispose to bacterial or fungal changes. What happens if you don't address it is you end up with, really worst case scenario, malabsorption and nutrition depletion disorders. Impaired digestion of fats, proteins, and carbs can then lead to impaired absorption of nutrients that are found in those macronutrients, in those fats, fat solubles A, D, K, E, B12, iron, zinc, all of the minerals will not get absorbed. With chronic malabsorption, it can lead to steatorrhea, which is fat in the stool. It can lead to diarrhea, unintentional weight loss, and then protein energy malnutrition, which means that they're just not living their lives and they're not thriving. And then with that, if it goes on and it's uncontrolled for too long, you end up with global nutrient depletions. This leads to fatigue, weakness, reduced exercise tolerance, and in severe cases, intestinal failure. Micronutrient deficiencies and hemologic patterns can also occur. If we're not absorbing our nutrients, we're missing our vitamin B12. So we might see megaloblastic anemia, glossitis, peripheral neuropathy. We will not be absorbing our fat solubles, A, E, D, K. So we might see night blindness, osteomalacia, low bone density, neuropathies, easy bruising, and then we're missing our irons. So we end up with iron deficiency, which leads to elevated folate from bacterial synthesis or lack of bacterial synthesis, and that can affect the function of the whole body. And then I always want to talk about, with fat malabsorption, I always want to talk about bone, because this is one of the reasons that we have to have in our mind for osteoporosis and osteopenia. If we are not properly absorbing our fats, either because of steatorrhea or diarrhea, we end up not being able to absorb our A, D, and K. Without absorbing D and K, we can't absorb our calcium, and so we can't build bones. And so that's why we end up with osteopenia and osteoporosis. Oxalate kidney stones due to fat malabsorption is another thing that can definitely occur. And then with that, we can also see neurologic symptoms like peripheral neuropathies, like gait disturbances, like cognitive changes, chronic fatigue, sleep disturbances. Really, they just have much lower quality of life. And that local gut damage and progression can lead to mucosal inflammation, villus blunting, crypt changes, that worsening diarrhea, dehydration, and electrolyte imbalances over time. So the small bowel workup is complicated. So let's take a look at what we can do and see how we can kind of prioritize when to do a small bowel workup. So what the first questions we need to start with, is there primarily a motility problem? Is there evidence of microbial overgrowth or excess fermentation? Is digestion incomplete because of enzymatic problems or bile insufficiency? And is there immune system or inflammatory processes that are overreacting that are driving symptoms? If we're focusing on gastric emptying, what we want to do is we want to measure the rate of how something solid, sometimes liquid, mainly solid, empties the stomach. So this is a really useful thing to look at for early satiety, nausea, vomiting. Suspected gastroparesis has to be worked up this way. And then upper GI dominant symptoms that affect downstream motility. We can use a small bowel follow-through, which looks at transit of contrast through the small intestine to rule out any kind of gross delays, strictures, and obstructions. We use this a lot with structural delay or partial obstructions, and we use it a lot with Crohn's patients. It's not very sensitive for functional dysmotility issues. It's much better for organic changes. And then radiation is it's there, and it's not great for physiologic changes. We can use a wireless motility capsule, which is a transit time through the stomach, small bowel, large bowel, looking at pH, pressure, and temperature changes. It's global. It doesn't explain why you have the motility disorder, it just finds it. It's, sometimes a refractory IBS or mixed pattern can be shown here and sometimes not. And it really is if you're suspecting some kind of dysmotility, but it is a very expensive test. And then our last option is doing enterographies, MR or CT enterography. My preference is generally MR enterography because there's no radiation, but it does increase cost. And this we're looking for organic diseases here. We're looking at bowel wall motion and contractility, as well as structural and functional information. It's best for IBD with some kind of motility disorder, for it avoids radiation, and it's looking for structural changes. It's expensive, and it's not great for standard motility disorders. It's only going to be great for obstructions or something like that. You can do a non-invasive functional motility workup. So basically, what we do is we're looking at functional testing of small bowel fermentation. This measures hydrogen and methane gases that are exhaled on a breath test. Gases are produced when microbes ferment carbohydrates in the small bowel. They're used with a time substrate, generally glucose or lactulose, if we're looking for SIBO in particular, and you take serial breath tests to see what's happening with fermentation over time. It allows you to understand if there's a presence or pattern of abnormal fermentation. It clues you in on motility, transit, and microbial activity, and it helps localize symptoms in the small bowel in particular. It is not a microbiome test. I am not, based on this breath test, able to tell you what bacteria is in there. I can just tell you what's happening with fermentation. Why the breath test? So the breath test is a direct small bowel sampling test. The small intestine is long. You can't really get there. It's largely inaccessible. Endoscopies miss it, colonoscopies miss it, and aspirates are expensive, and they're going to miss most of the small intestine. So basically, we use breath testing as a functional surrogate. This measures fermentation in different fermentation activity, not orgasms directly. It reflects what the microbes are doing, not just who's there, and it provides a direct insight into location and transit. It identifies abnormal gas patterns that are localized to dysfunction in the small bowel. It is a complement to other testing. It is not a replacement. The fermentation location tells you the timing where the gas rises, so where fermentation is occurring. An early rise suggests proximal small bowel activity. A later rise would tell you there's more issues with colonic activity or further down the small intestine. Hydrogen is elevated in bacterial fermentation. Methane is elevated in archaeal metabolism, now known as IMO or intestinal methanogen overgrowth, and you can have a mixed pattern. The magnitude of the gas elevation reflects the degree of fermentation burden. A higher burden tells you that there's more load. And then a flat or erratic curve might suggest some dysmotility, or it might suggest there's another gas or something else that's happening. Really, we use this as a guide to treatment. It helps explain to us what we should be prioritizing. I do quickly want to touch on substrates, glucose versus lactulose. This is definitely a little bit controversial. Glucose is rapidly absorbed in the proximal small intestine. Results will signal proximal small bowel fermentation. Glucose has a lower risk of false positives. If they're positive, they're definitively positive, but it might miss distal small bowel growths. Lactulose is a non-absorbable disaccharide that travels through the entire small bowel. It is much better at identifying distal small bowel fermentation. High risk of false positives if transit is rapid. So this one is more likely to also cause diarrhea as a side effect. And I will tell you that there is no agreement across the gastrointestinal world about which substrate is best. We have ACG, which utilizes lactulose more than glucose, but glucose is acceptable, and they have clear parameters. And then we have AGA that leans towards using glucose over lactulose, and their parameters are not as hard-line. So let's just quickly go over the SIBO breath test because it's pretty important. So when I'm looking at a SIBO breath test, what you'll often see is you'll see this Excel-like document with different numbers and those numbers graphed. We're looking at those numbers to tell us how things are supposed to look. We generally tell patients to do a prep diet. That prep diet includes protein, fish, poultry, lean meats, tofu is also fine. That's plain hard tofu, eggs, white rice, white bread, no fiber, no herbs, salt and pepper is the only spice, no fruits, no vegetables. And they do that for 24 hours with a diarrhea pattern, or 48 hours with a constipation pattern. We avoid all fruits, all fruit juices, all vegetables, all legumes. Tofu is the only thing that's okay. Nothing sugary, nothing sweet. It's a very boring gray diet. Baseline hydrogen must be under 20. This tells you that they did a good prep diet. A hydrogen that's above 20 parts per million means that the rest of the test is kind of off kilter and you can't really bank on it. And then methane, a positive methane is any methane that's over 10 anywhere in the test. So let's look at this. So when I'm reading a SIBO breath test, I am starting by looking at the Excel spreadsheet. I don't look at the graph. Baseline hydrogen, any hydrogen under 20, I'm like, great, you're good. And then I'm looking in the first 90 to 100 minutes to see if they have an elevation of 20 parts per million. That is going to tell me what's happening. An earlier rise will tell me that there is small bowel fermentation in the proximal intestine. A later rise will tell me that it's distal small bowel or possibly colon. Methane doesn't actually respond to the diet. It does its own thing. So I am looking for any methane anywhere that's over 10. Methane is not caused by bacteria. It's caused by archaea or methanogens. Methanogens are known to slow transit. And then we have the carbon dioxide correction. The correction is a quality control mechanism that's used to ensure that breath samples are truly reflective of lung air and not room air that's exhaled. Carbon dioxide matters because it tells us it is confirming what we are testing. This is why I just want to go on a quick tangent about quality of machines, because there's a lot more breath tests that are currently available. In my opinion, the only one that has ever been validated is the Quintron machine. The Quintron machine has been around since the 1990s. It has excessively been validated to aspirate to confirm that we're seeing what we're seeing. It also has corrections in place to make sure that our carbon dioxide numbers are correct. The SIBO test measures carbon dioxide along with measuring the hydrogen and the methane. And so the machine has to be able to properly calculate what's carbon dioxide, what's hydrogen, what's methane. If the hydrogen and methane values are adjusted, then carbon dioxide should be low. And so that's that adjustment or the correction. Okay, so let's look at some tests and figure out if they're positive or negative. So here we have a test. First thing we're going to look at is hydrogen and methane. Baseline hydrogen of 3, we go positive at 32. That tells us we have a positive hydrogen test at 100 minutes because we have a 20 part per million elevation from baseline. So now let's look at this methane test. So methane, we start by looking at 19. Our baseline methane is a 19, which means right from the get-go, that methane is over 10. It is positive. And so this is a positive methane test. So I'm hoping that clarifies what you're looking at. If your baseline hydrogen is over 20, that is not a valid test. If you have any methane reading that's over 10, that tells you should go after treating methane. And you really want to make sure that your test has been validly done with a machine that actually has been validated in the research. Let's talk about digestive insufficiencies. So basically, this is caused by the impaired breakdown of food before absorption. This is some kind of inadequate mechanical, enzymatic, or chemical digestion. It occurs upstream of nutrient absorption, and it can be an issue with gastric acid, pancreatic enzymes, bile salts, or coordinated motility. Nutrients can be present in the diet, but biologically unavailable. We've got stomach, which causes acid-mediated protein denaturation, a liberation of minerals and B12, pancreatic enzymes, proteases, lipases, and amylases, bile production, fat emulsification, and then also in the small bowel, we can have brush border enzymatic activity and coordinated transit. Failure of any of these could cause downriver effects. Common digestive insufficiencies, hypochlorhydria, achlorhydria, EPI, impaired bile flow or bile acid deficiencies, post-surgical changes like gastric surgery, cholecystectomy, inflammatory processes and mucosal inflammation, also aging, and then medications. Prior digestion feeds upstream microbes. So basically, incompletely digested proteins or carbs can create more fermentation, which contains the bacterial and archaeal growth of the GI. And then reduced gastric acid can lower antimicrobial defenses, and impaired bile reduction also affects bacteria. So if there is some kind of digestive insufficiency, there is a risk for developing more bacterial overgrowth. It's not just a consequence of bacterial overgrowth. And it can be self-reinforced. So basically, if you have bacterial deconjugation of biles that are not working, you have reduced fat emulsification, which leads to fatty stools, fat-soluble vitamin loss, and then oxalate absorption, which means you are not absorbing the rest of your nutrients. You can have a brush border injury or inflammation of the small intestine, which then can change the microbes because you're getting a difference in how you're breaking down your disaccharides and pepsidases. You can worsen carbohydrate intolerances, and then there's gas production that affects motility, and eradicating microbes without restoring digestive motility will lead to a relapse. Okay, and then there's the immune section to this. Chronic stimulation of gut-associated immune tissue can cause issues. The small intestine is generally an immune organ as well as being a digestive organ. And so if there's a lot of small bowel immune activation, you end up with chronic microbial exposure or overgrowth. You can end up with post-infectious issues like post-infectious IBS. And then there's that correlation with immune overreaction and then organic diseases like inflammatory bowel diseases and celiac, and then chronic stress can affect the HPA axis. The SIBO activates the immune system, and the immune system activation can promote SIBO. They go in both directions. Immune activation will impair motility and digestion by affecting the MMC. It promotes bacterial growth by increasing stasis to allow fermentation to then shift the microbiome. And then it amplifies immune activation, which then exposes you to more pro-inflammatory cytokines, which can affect intraepithelial lymphocytes and cause more pathology and disease. Okay, that was Burley. That was the small bowel. We've got just a couple of minutes left. I'm going to power through the large bowel, and then we're going to answer questions. So large bowel, colon-driven pathology is more likely when you have diarrhea or constipation as the dominant symptom, minimal bloating or abdominal distension, stool form and frequency are often the primary complaint, and symptoms often improve after bowel movements. You might see rectal urgency, mucus, and tenesmus. The colon is a fermentation and water handling organ. It's primarily a dysfunction of the stool patterns that you see with large bowel diseases. The colon, however, colon can also be secondary to small bowel or gastric dysmotility, especially if there's motility shifts up top. You will just generally see them with some of the other symptoms we talked about earlier. Stool testing is the testing of choice for the large intestine. A stool sample can absolutely show us the colonic microbiome of the small bowel. When to think about the small bowel? When there's diarrhea or constipation as a dominant complaint. Minimal postprandial bloating, symptoms are tied to defecation, and pain is lower bowel rectal. Stool and bowel movements are the main problem, and they might be malodorous, abundant, or loud. Poor digestion, the colon might be reacting to poor digestion, bile, or small bowel dysbiosis, and you'll generally see other symptoms at that point. You always want to start by ruling out organic disease, inflammatory processes, structural diseases like strictures or obstructions, malignancies, and infections that are more rapid or severe. Testing for large bowel involves colonoscopies, calprotectin lactoferrin looking at inflammation, CRP or SEDRATE looking at for systemic inflammation, and CBC. You have imaging options and you have stool cultures as options. And then you want to look at infectious panels looking at stool PCRs, ova and parasites, or antigen testing. If the lab or imaging is positive, you want to refer to a subspecialist that can navigate that while you work on the adjunctive support. Structural diseases could absolutely cause huge issues and present with any of these symptoms. CT or MRI of the pelvis or with contrast, colonoscopy when it's safe, and abdominal x-ray can rule out acute obstructions. And then malignancies are ruled out with colonoscopy, CTs, and CBCs. Rule out danger before you label it functional. Red flags. Chronic inflammation, systemic disease, anemias, inflammation, bleeding, nocturnal diarrhea, rectal bleeding, familial history of IBD and colorectal cancer will kind of put you in that direction, and then persistently elevated inflammatory markers. Inflammatory patterns include fecal calprotectins, lactoferrins, systemic symptoms, and then once those are ruled out, you can start thinking about your functional disorders like IBS, like diarrhea, constipation, dyspepsia, stuff like that. When you stool test, the time to choose a stool test is if the colon is suspected as a primary driver, after the small intestine has been addressed, if you think it's both, or in chronic refractory conditions. You are looking for inflammatory markers, you are looking for pathogenic agents like parasites, protozoa, dysbiosis, and then digestive markers. Functional stool testing for constipation is really interesting. There's a lot of different types of constipation. Slow transit constipation affects motility. You have reduced colonic motility. You can have outlet or dyssynergic defecation, which is a pelvic floor issue, which the keynote for that is you give them laxatives and it makes no effect. Or you can have a structural issue like a mechanical obstruction, tumors, volvus, fecal impaction, strictures, or severe diverticular diseases. You can also have functional and organic diarrheas. Organic diarrheas are going to be caused by some kind of primary organic disease. And then functional diarrheas are going to be stress-induced, rapid gastrocolonic reflex. Often meals will be a trigger, and it's triggered by some kind of dysregulation. When you're working this up, you want to rule out organic disease. You want to address issues upstream. You want to target colonic-specific issues, and you want to reassess and then test. That was Burley. I know I talked very fast, but I'm in at the 15 minutes. So I'm ready for questions. Let me know if you have any. Also,